I know a lot of people came in and saw this psychiatric approach to myositis and probably got out there, got confused, but it's actually not psychiatry, it's physiatry. By the way, my name is Dr. Chung. I'm one of the doctors at Johns Hopkins Myositis Clinic. I have a little different background than other neurology or rheumatology doctors in myositis clinic. I had residency training background in physical medicine rehabilitation, but then I did my fellowship under Dr. Manman for nerve and neuromuscular medicine. So I see patients in myositis do the same things that other neurologists or rheumatologists do. But I have a particular interest in exercise and rehabilitation in myositis care. Now, today, this is more patient conference. I wanted to talk about more something practical things that you can go home with. And this is actually kind of part of it. We'll talk about exercise a lot today too, but I have another talk tomorrow morning, focus a little more on exercise. But before I talk about some specific exercise protocol and everything for myositis, I thought it's really important to understand the concept behind therapeutic exercise and rehabilitation. So I intentionally kind of use this kind of weird term called physiatry. Now, so has anybody here heard about the term physiatry or physiatrist? Can you raise your hand if you ever heard about it? So can you tell me what this is? I want this to be more interactive. I don't have a lot of slides. You can raise your hand and interrupt me anytime with any questions. So, right, you do EMG, but neurologists do EMG too. Any other ideas? First of all, exactly. Right, that's a good one. Does anybody know how to pronounce this by any chance?
Physiatry.
Okay, well, you can do physiatry or physiatry, like tomato. Yeah, it's called physiatry. It's not a psychiatry. It kind of sounds very confusing. It looks confusing. We do very different things, as you can see. So psychiatry is a mind. We do body stuff, right? And it's the same as physical medicine rehabilitation. It's a little too long, so we actually made one word, which is physiatry or physiatry. Or in medical community among doctors, we just say PM&R. So what is physiatry then? And then again, I think it's really important to understand this concept because a lot of myositis patients have disability and other issues on top of all these medical things. And I know you did a lot of other lectures today talking about different medications and pathophysiology of myositis, but for this one I want to talk about a little more other issues related to myositis. Now, it's a medical specialty, so it's actually residency training by medical doctors or DO degree. And we are a lot of people ask me if I'm a physical therapist. We're a little different, although we work really closely with physical, occupational, and speech therapists. And in fact, so-called PTOT and speech therapists are very, very important part of physiatry. But we have a little bit different roles, and I'm going to talk a little bit about how we work together. And as a patient, I think it's important to know how we work together. Now, physiatry is a little different and unique medical specialty in that we focus on disability and function rather than disease itself. Now, for example, everybody knows what cardiologists do, right? They take care of their heart. Everybody knows what GI doctors do. They take care of GI problems, right? But we take care of function. So what exactly you mean by function? I mean, my brother is a doctor too, and he still doesn't know what I'm doing. And I'm pretty sure he doesn't know how to pronounce physiatry either. So it's kind of complicated, so I can't blame all the patients not to understand what we do, although I think probably you guys can benefit from understanding what we do. Now, so we're not really focused on single diseases or single organs. We are basically population-based. And what are the population we're dealing with? Any population, any patients who have disability. and I'll go over more on disability term, definition of disability, but basically any functional problem. So again, you can think about pediatric or emergency medicine. It's kind of like that. I mean, we are not focused on certain disease. So pediatric doctor, pediatricians, they don't only see GI problems or only see heart problems. They actually deal with the entire pediatric population because across all the diseases or organs, there are very unique things about being a kid or something like emergency medicine. But PM&R, physiatry, we feel that regardless of what the disease, what kind of disease they have, the common factors of disability, and there are unique things that we can do, like unique approaches we have for those functional problems. So what do we mean by function, disability, and everything? So there's actually pretty clear definitions, and I think, again, this is not to try to confuse you or anything like that, but I think it's important and probably beneficial for you to understand different concepts. Now, we use this term impairment, and impairment means really just physiological, anatomical problem. Like, for example, myositis. We know myositis is inflammation of muscle. Autoimmune inflammation of skeletal muscle is myositis. And impairment means basically degeneration and inflammation of the muscle. And impairment, basically this is the issue that a lot of other doctors are talking about today. Medication and everything. If it's arthritis, it's joint. If there's a heart disease, it's a heart, coronary artery problem, and so on. Those are impairment. Whereas when you say disability, it's a functional restriction, limitation to certain function. Now, I'm talking a little more about physical function. Of course, actually part of a PM&R, we deal with some psychological problem too. But let's focus a little more physical function. When I say physical function, probably because of impairment of tissue, whether it's nerve or muscle. If you can walk, which is a function, or having weakness and having hard time negotiating stairs, that's also a function as well, right? In eating, some myositis patients have difficulty swallowing, and that's a function too, right? So those are, and any limitation in function is defined by disability. Now, what do you mean by then handicap? Handicap is a little different aspects of whole disability. Basically, it's a limited social integration. So, in part because of impairment and or disability, for example, if anybody can access to a building who's on the wheelchair, they can't really get into the building, or public toilet because it's not really equipped. So the interaction between society and access is more handicapped. So now I know you guys are a little bit confused, but let me allow me to confuse a little more. Now, impairment, disability, handicap are not the same thing, and it doesn't always go together. Like, giving an example. Let's say maybe some of you may have diagnosed with amyopathic dermatomyositis. Meaning this is a type of myositis manifesting skin problems, but doesn't have any muscle weakness, for example. So they do have impairment because they are diagnosed with myositis. So they have inflammation in certain tissues. So they do have tissue impairment, but because they don't have weakness, it doesn't involve muscle. They may not have disability. They can walk around fine. They may not have any problem, waking up and walking around, eating food, and do their work, and driving and everything. They may not have any problem. And also they may not have any problem integrating and accessing to certain buildings, may not have any handicap. Whereas, give another example. My distant cousin, he has a spinal cord injury, high-level spinal cord injury in a wheelchair, but he's completely independent. He can do pretty much everything on the wheelchair. There's actually really nothing he cannot do. He actually went to medical school after he became a spinal cord injury patient. So for that patient, in that case, he definitely has an impairment. He has a spinal cord injury, a nerve resection, and he doesn't have any muscle. He can't really contract any muscle down below the waist. But functional standpoint, he can do whatever he wants. He can write, he can drive, he can, he finishes his entire medical school. And he, depending on his social situation, he may not have handicap either, because he can complete access to everything that he wants. The other extreme cases, let's say the patient with dwarfism. Well, technically, there's really no impairment. I mean, it's a genetic condition. They're kind of small people. They may not. So there's probably no tissue impairment. It's a genetic kind of congenital anomaly. So it's not really there's tissue anything wrong in their tissue. It's just that because they're kind of small figure, they may have some difficulty. Maybe have a little bit of disability, but mostly with the handicap, because all those tables and chairs are all designed to fit into just normal kind of adults, and they may not have any access to that too. So again, impairment, disability, handicap, they don't always go together. Those are the same thing. And I think kind of understanding this concept is really important, because as a physiatrist, our approach is a little more comprehensive. So any disease, whether it's myositis, I mean, we are all myositis patients here, so we're focused on myositis, but any diseases, they have kind of 3 different phases, which are impairment in their tissue or anatomical structure, but they can also result in disability, problem in function, and also handicap or integration into the society. And again, as a physiatrist, we're trying to approach more comprehensively. Now, let me give you an example of how we do it. So imagine, there's no particular patient here, but imagine there's a 65-year-old male who's been having kind of progressive muscle weakness. Let's say test results are all consistent with inclusion body myositis, meaning their muscle biopsy shows a lot of inflammation, maybe vacuoles, and CK, which is muscle enzymes, are high, and all objective findings or impairment that's consistent with inclusion body myositis. And as a result, he has progressive muscle weakness over some years in the upper and lower limbs. And also as a result, he falls down frequently, at least a few times a month, and he has difficulty swallowing, and so on. So what do you do? So how do you do differently as a physiatrist when you take care of this patient? Now, first, remember these 3 different concepts, 3 different approaches. First, impairment is actually the most important thing, just addressing the impairment. So I'm not going to talk too much about treating impairment, because this is pretty much all the talks about at the conference. I know there have been talks about different medications, neuromedications. Basically, the goal to treat impairment is to treat literally the tissue impairment. For myositis, we're treating the muscle inflammation. All the medications that we've been talking about, we're trying to manipulate the immune system to suppress the inflammation and restore the muscles and everything. So those are the impairment treatment. And again, we can potentially use IVIG, steroids, methotrexate, and all so-called medical treatments are all under this category of treating impairment. And also, so that's actually, people get a little bit confused about this, but I focus a little more on tomorrow's talk. But therapeutic exercise is also under the treating the impairment. Sometimes we know, especially for poliodermatomyositis, we know certain types of exercise can address basic pathophysiology and try to help facilitate the regeneration of muscle from myositis too. So with the combination of medical treatment, drug, and also therapeutic exercise, we are addressing the basic impairment. Now, so those are, I don't have to explain too much about this, but so what do you mean by disability? So how do you approach the disability? Now, first of all, So on top of identifying the impairment, which is muscle inflammation, we have to try to identify the functional problem. Like for example, in that case, difficulty walking and frequent falls. So, those are functional problems. And walking is actually really one of the most important functions in anybody's life. So those are one of the most important things. Difficulty swallowing, eating is obviously very important for anybody. Difficulty, because of some IBM patients have hand weakness and they may have fine motor skill problem, like buttonings or typing things, and depending on their jobs, that could be a major problem in their life too. And also difficulty with some heavyweight lifting for the groceries and stuff like that. Now, let me give you, so addressing these different aspects of this function or disability may be a little bit complex and it's probably beyond the scope of this talk. So let me just focus a little more on the walking. Because as I said, walking is usually one of the most important elements of function in anybody's life. And very important for independence. Now, how do we approach gait problem? First of all, we first have to identify the problem, right? So when they have difficulty walking, what kind of problem do they have? Is it because of balance? Is it because they fall too much? Or it's just, they are too weak and too slow and, it's just not practical, right? And there are a lot of other things to consider too. People don't really think much about when it comes to walking. There are a lot of practical issues as well. I mean, not for a lot of myositis patients, but for patients with a spinal cord injury patient, they don't have any bowel and bladder control. And if they don't have a lot of control over their bowel and bladder, really there's no, practically they may not be able to kind of walk around the street even though they can't actually walk with their legs, right? So there are a lot of other different aspects that you have to consider. And secondly, you have to analyze the gait. First of all, do they walk in an appropriate speed? Is it too fast, too slow, too impulsive, or do they have a good turning balance, or are they going to really the right direction? Or depending on some people with the brain dysfunction, they can probably walk beautiful, but they may go into the completely wrong direction too. And can they avoid obstacles? Can they walk on the uneven surfaces and all these different environments? Is it okay? And again, other consideration, and also some important consideration, especially the level of activity. This is one of the things that a lot of patients actually don't think much about, and that determines how aggressive we have to be for this gait, fixing the gait problem. I mean, I was in the previous talk about exoskeleton and robotic orthotics and all that kind of technologies, but is it really practical? I mean, my approach to patient who's in a nursing home, probably 90-something years old, is probably not really walking around that much, versus somebody who's in his 40s and 50s, have kids and breadwinner, going to the work. I mean, my approach is going to be very, very different, and I should be very more. And these people who are working, independent and breadwinner, they probably have to be should be able to walk, and I'll be more aggressive in terms of having them walk for a longer period of time. And again, I mean, this is a little weird question, but do we even have to fix a problem? Again, these are people who are, it depends on their lifestyle as well. So in their environment, age, and everything should be into consideration. Now, I know we have a lot of IBM patients here, and IBM is actually a really great example of this physiatric approach to the gait. So now, typical gait problem in inclusion body myositis is the so-called knee buckling, and because of the quadriceps weakness. Now, a couple of things about the gait is that, well, gait is actually really not much about the muscle strength. And And because of that, and it's actually a lot about sensory information processing. So meaning, when we walk, we don't need a lot of muscle strength. There's actually some studies showing that you need to have just a little bit of muscle strength in hip flexors and quadriceps, and that's pretty much all you need for walking. And because and everything else is actually more about the sensory function. So a lot of myositis patients, because it's a more pure motor problem and muscle weakness, and myositis patients usually have very intact sensory function. Myositis patients actually walk pretty well given the level of muscle weakness. And there's a little bit of difference between poly and dermatomyositis versus IBM patients who have more distal muscle weakness. Poly or dermatomyositis is purely proximal muscle weakness. They have a hard time getting up from the chair, but once they stand up and get up, they can actually walk without any problem, and they almost never fall. Now, IBM patient, inclusion body myositis patient, they actually have frequent falling, and it's usually a purely mechanical fall. Now, when people walk, like I said, unfortunately, one of the most important muscle is actually thigh muscle, which is knee extensor. And what the knee extensor does is, when you're advancing the knee on the ground, it kind of slowly advances the knee at the thigh level. And when they have a thigh muscle weakness, they just collapse and fall down. So usually, almost subconsciously, most IBM patients compensate this problem by putting their knee back, and it's called knee hyperextension or geniculum. So if you can look at the picture here, when they walk, some of you might actually notice that they actually put their knee back to stabilize their knee, and it's called geniculum or knee hyperextension. And this is a very subconscious process. Now again, like I said, walking is more about sensory information. So, like I know a lot of IBM patients who has almost zero muscle strength in the knee extensor, which is thigh muscles, but they can actually walk pretty well with this hyperextension of their knee, because they can still stabilize it, and they can still, walk around with the remaining muscle strength there. However, they still fall down because usually on kind of a couple of occasions when they are walking on uneven surfaces, and if they step on certain stones and everything, they cannot hyperextend the knee and they buckle and fall down. Or if they walk for a long period of time, their muscles get exhausted, and they can just it takes just one time. If they can put their knee back, they buckle and fall down too. Or again, walking is more about the sensory information. If they're walking around and got distracted, they're walking around the big city, overcrowded places, and people are bumping, they got confused, they forget to extend their knee, they buckle and fall. Or they're walking, watching their phone, they forget and they fall. So those are the occasions when they fall down. So understanding this mechanism is actually really important to kind of prevent, establish the strategies for preventing the fall. So what are the strategies are there? First of all, if they're not really falling all the time, and they're just kind of stumbling a little bit, cane actually can be sufficient. Or it doesn't even have to be a cane. A walking pole or anything, could be very helpful. Basically, why cane works? It basically gives extra sensory feedback. So basically what it means is that, again, myositis patients usually don't have any sensory problem, and they still have sensory information coming in through their skin and vision, and then that processes the spinal cord and brain and react to it. But when they fall because their reaction time is a little slow, and they don't have enough muscle strength to correct themselves. So when they have cane or walking fall, basically it just gives them a little more extra sensory feedback, so that they can be more prepared for any unexpected events. So actually cane, as simple as a cane, can be really helpful. And I know a lot of people kind of underestimate the power of cane, so I actually put this picture. It is really powerful for a lot of people. I mean, people can't explain why cane help, because you don't really lean on, you're not supposed to lean on a cane. You're just kind of walking around with a walking stick. And still, it can be really powerful and really helpful too. So, and I've also noticed that a lot of people, when they come in to my clinic, I think just for guys, they don't want to look older, something like that, and they try not to use cane or any assistive device. I can tell you there's a lot of fancy canes. It can be an umbrella, it can be just anything. Actually, I noticed that when you walk in, and that's a great idea too. The gentleman has a baseball bat and made it to a cane too. So yeah, it can be just very creative, you know, maybe for ladies, some Hello Kitty or something like that. But really, really helpful. So bear in mind, especially when you're walking on uneven surfaces in a crowded area, you know, please consider using a cane. You don't have to really, you know, get prescription for that. You just can buy anywhere. Another benefit of having a cane. Yeah, I mean, it may look a little older, but a lot of people actually, when you're walking around with your cane, people are actually really nice to you too. Last year, I actually had a little torn muscle for just a couple of days, and I had to use a cane for a couple of days. I was actually really surprised when I went to Starbucks. I didn't have to get in the line, and everyone's just really nice. And if they're not nice, they can. So okay, so cane, sometimes cane is not enough. I mean, they still fall down a lot, and again, falling is actually something very serious. And IBM or myositis usually are not. I mean, it depends on different subtypes of myositis and how they get the myositis, but usually myositis are not really the life-threatening conditions. It's not like cancer or any other, you know, fatal conditions. But fall can be pretty fatal. It takes just one bad fall to have any really, you know, bad consequence. So the preventing fall is actually really one of the main things, especially in my clinic. And if they start falling, there are certain type of braces we can actually use, and especially for IBM patients, it can be you know, really powerful. It can significantly reduce the fall. Now, I don't know. Maybe if you guys are involved in this myositis community for a little long time, I think several years ago there have been some discussion about certain type of braces for inclusion body myositis, and I know there have been some couple of clinical studies on it too. And the particular type of brace that they studied before is called KAFO. It's a pretty big brace that covers the entire leg. And basically that prescription is based on biomechanical analysis of their gait. Basically the brace beautifully fixed their biomechanical derangement. However, I feel like that, but unfortunately that never took off. And I mean, I've almost never seen any IBM patient actually using that brace. And even in their clinical studies, they actually gave out those big braces, pretty expensive big braces for free. And they turn out that almost nobody actually uses it. And that actually goes back to the same kind of you know, issues with the walking. There's a lot of practical things about walking. If you have this huge, heavy brace, now you have an IBM, you may have some hand weakness. How are you gonna, you know, carry around? I mean, almost like it fixes your doctors. I mean, you know, if I see a patient with hyperextending their knee and walking the rear and put the brace, it beautifully fixes their biomechanics. But my goal is actually to have the patient to walk better, and walking is, for me, it's basically just getting from A to B efficiently, right? So that's my goal. It's not my goal to fix the biomechanics or any numbers. And I feel like kind of that brace is kind of, you know, ideal in that it fixes the biomechanics, but you know, it's probably not practical. It's just too heavy. How are you gonna kind of carry around, walk around? I've been working with actually a brace specialist in my clinic, and he came up with actually this nice idea of this technical name for this brace is called ground reaction AFO. AFO means ankle knee orthosis, and it's more carbon fiber because it's a carbon fiber, it's super lightweight, and it's ground reaction. It's actually kind of wrapped around in the front of the shin there, and basically what it does is actually it kind of even promotes the pathological gait pattern, which is hyperextension or genuine curvatum. So we found that, if we actually promote genuine curvatum, actually they work even more stable. So although we are not fixing the biomechanics, on the contrary, we are actually promoting this pathological gait pattern. But we found that this is actually helping more. This actually reduces the fall. I've almost never had any patient who fell on this brace. So to me, they're actually walking, kind of better and with a more confident and definitely with less falls. So it kind of satisfies my goal for treating the function. Yes, please.
What was the name of this brace and what would you call this brace?
The technical name for this, ground reaction. Ground reaction. AFO, ankle knee orthosis, with carbon fiber. AFO, not the AFO, ankle foot orthosis. I'm sorry about that. With carbon fiber material. Now, and another thing that I wanted to tell you, emphasize is that, and there was actually another question from the other session too. Actually, this type of brace, you can go to Target or CVS, there will be something there too.
I wear one of those and it shortens up your gait and slows you down.
Excuse me? Can you?
I say I wear one of those.
Okay.
It shortens your gait and it really slows you down.
Okay. Does it slow you down? Yeah.
On the other hand, I don't fall because of that.
I see.
I have foot drop, so that's the purpose of it.
So yeah, as the patient, gentleman said, that's true. It slows you down, but again, the primary goal for this AFO brace is to prevent the fall. And there's a little bit of the reason that we use carbon fiber is there's a little bit of elastic recoil. So it kind of depends on too. Actually, if you have some other muscles function remaining, you can actually use that recoil to walk. I'm not gonna say you're gonna walk faster than before, but the gait speed doesn't necessarily get affected all the time, depending on like whether how much muscle are compensating certain function. And another thing that I want to emphasize is that again, you can go to CVS and Safeway, any place, Target. You can actually buy online or just buy it yourself. But I really recommend not to do that. Bracing exercise is kind of it's just an art and science. It takes a lot of kind of good analysis and kind of clinical judgment, and just a little bit of kind of changes in the design can make a lot of difference. I know a patient who bought this brace online and put a little small kind of elevation in the heel, and he actually falls more. And it's kind of hard to explain all the biomechanics behind this AFO and everything. One of the things is that there's really no regulation on this type of braces, and I feel like the brace, again, the specialist is called orthotist. In this country, there are only a few states that you have to be certified orthotist to deal with this bracing and sell the brace. A lot of states, you can be just kind of used car salesman, and the next day you can actually sell this brace. And I'm telling you, it makes a lot of difference. So just try to make sure that you just don't go buy in Walmart. Just try to talk to your doctor, and physical therapists can help you with this process as well. another strategy, so again, like I want to go over some more practical strategies too. Rolling walker is another good thing too. I actually really like rolling walker. Pretty much everybody knows about rolling walkers, and you've probably seen it in the airport all the time. I've seen it here too. It is great for long distance walking. So whether you walk with a brace or just a cane, if you're not comfortable or confident walking or stumbling a little bit, this is actually a great practical solution for long distance walking. For example, like this area, large conference place, airport, you just walk with a walker, and you can. Usually there's a seat. You can actually sit and rest in the rest, and as you can see, you can actually carry a lot of stuff in the walker. So for many reasons, I actually really love this rolling walker, and it's actually not that heavy. Oftentimes, even if you have a small car, you can actually carry in your car. Very practical solution for a lot of things too. Yeah, and you don't really want look that older. So not older. So now the wheelchair is one of the things that I try to avoid as much as possible, and for many reasons. For myositis patients, as you can see, there are actually different types of wheelchairs. And first of all, wheelchair. When you say wheelchair, it must be custom fitted. Okay? So you can still say it's a wheelchair when you go to just market or shopping mall or airport. There are some kind of wheelchairs which is not custom fitted. That's not your wheelchair. Still you can call it as a wheelchair, but it's not really not yours. You shouldn't be using those wheelchairs not custom fitted for you. Now there are different types of wheelchair, and before you get into the wheelchair, there are a lot of things you have to kind of consider as well. For myositis patients, most of the time, they're not, unfortunately, manual wheelchairs are not indicated for most of myositis patients. A lot of myositis patients have proximal muscle weakness, and actually you have to have some pretty good certain muscle strength, usually in the proximal arm muscle strength to propel yourself, and that's really usually the case for muscles that are affected by myositis patients. So fortunately, we can prevent going to the wheelchair for long term for myositis patients, but once you get to the point where you have to use a wheelchair, usually it's actually a motorized wheelchair. And if you use a manual wheelchair, now a lot of things you have to consider. Who's pushing? You have to, because you can't propel yourself, you need to have somebody constantly pushing you, and also carry it for you too. Again, there are practical issues you have to consider, and also prevention of falling. And also, if you have a wheelchair, access is another problem too. You probably have to have a kind of van that can access the wheelchair if you want to use this wheelchair independently. Now, another really important thing that I also want to emphasize is motorized wheelchair is not same as scooter. Anybody knows any difference, by any chance? So I've seen today a lot of people actually using scooter, but not many people are using wheelchair. And this is actually a scooter, not a wheelchair. Well, I think scooter is actually good too for certain things. I'm not saying that you shouldn't be using scooter, but I've noticed that a lot of sometimes insurance companies or some commercial vendors, they advertise scooter as motorized wheelchair. That I feel like that's kind of unethical. And scooter can be actually, you have to be kind of careful, because scooter actually doesn't have the safety features. It can actually tip over. Scooter is literally just a scooter. It's a motorized wheel and just kind of get around. A wheelchair, again, is custom fitted and has a lot of features, especially for myositis patient. Should have some tilting kind of space, or can move around and kind of flat, and also has to have some cushion that prevents pressure sores and everything too. So just make sure that, and also if you, the insurance is a little tricky. If you get a scooter, you may not be able to get the wheelchair too. So again, when those companies are trying to sell their scooter, just be careful what you're getting into. And for myositis patient, again, manual wheelchairs are usually not indicated. I'm trying to keep their walking function for a long time with the bracing and cane, but once they get to the wheelchair, usually it's motorized wheelchair. Now I know a lot of people are also very interested in this neurotechnology, so-called exoskeleton. I don't know if anybody heard about it. So basically this robotic, it's not a brace, it's an exoskeleton. So it's a robotic machine that basically kind of helps you with the walking. And I don't know if you guys ever seen anything like that in the TVs or YouTube. You know, DoD is usually funding this kind of research and for paralyzed veterans. And even this previous talk, I know a lot of people have been very, very interested in this exoskeleton. Now, a couple of things that to consider. Now, the research is actually not to the point where it's really, really practical. I mean, even early this year when I went to the rehab conference, a lot of companies came to the talk. Currently, there are probably several companies that make this exoskeleton, and that looks really, really fancy. I don't know, have you ever watched the Alien movie? Like Alien, they put in the machine. It's kind of the same concept. The problem is the battery is actually the main problem at this point. The longest battery is 4 hours at this point, 4 to 5 hours. And if you imagine, if you walk around with this exoskeleton, which is really huge, and after 4 hours, it's going to stop in the middle of the road, and there's nothing you can do about it. So that's actually a real problem. And second thing is actually stairs. This exoskeleton can do stairs. At this point, there are some companies that are claiming that they resolve this problem, but not like as safe as you can, reliable. It's not, you can't actually do stairs. So again, with a short battery and no stairs, it's really not practical at this point. I'm still very interested in the development because even just several years ago, we went to the same conference. The battery was much shorter and much heavier. Like every year, it's getting better and better. But again, just for now, this is a little more for therapeutic. So meaning they use this exoskeleton in the physical therapy gym to walk around, to kind of train walking, but it's not practical for actually kind of community walking at this point. So that's actually more, most important things about the gait. Now, difficulty swallowing, like I said about the function. What do you do about it? Usually, now we call this speech therapists, but the speech therapists actually do a lot of swallowing evaluation and treatment as well. So it's usually evaluated by speech therapists, and depending on the pattern of their swallowing problem, again, we are approaching this functional problem, and they can just change their consistency of some foods. Depending on the type of swallowing problem, it can be just some solid food, or it can be just liquid, or and depending on their evaluation, we can just modify this problem and prevent aspiration pneumonia or other consequences as well. And you can also fix a problem by this procedure called as dilatation. Or this is one of the things that we have in our data. Well, we found there are a lot of swallowing problem in myositis patients are caused by muscle weakness around the neck, and there are certain therapeutic exercise that can actually address strengthening the muscles involved in the swallowing. So now the last one is handicap aspects of it, and again, this is a little more than just medical. So again, handicap is more the limitation of social integration. And now let's say if you have a wheelchair, how do you access to the wheelchair and use of a public toilet? And these are the things that we have to consider when you use certain equipment or wheelchair. Is it safe to use just public toilet? How do we do that? Or we can also talk about home therapy, or maybe kind of staying in a nursing facility for a long time if you don't have enough caregivers. So a lot of these issues involving handicap is really more kind of social things, and you probably want to have any therapists or social workers who are very familiar with this, different types of resources. And again, it's a little more kind of medical. It's more about how we get around safely and taken care of by different people very safely. Now, just to summarize what I've been talking about, again, there are three different aspects of disease, which is impairment, disability, and handicap. And Odo talks about the medical treatment, steroids, methotrexate. Basically, it's just to fix the impairment of the tissue. But physiatrists, as a physiatrist, we approach a little more comprehensively and see the disease in a little different aspects, which is a disability or a handicap. And the reason that I talked about this is that maybe just for yourself, even today, you can think about what are the functional problems you have, or what are the handicaps or limitation to access. And probably it's helpful to identify those problems and to know that there are certain solutions for those functional problem or social integration issues, and physiatrists can actually help you with those solutions. And as you can see, as you saw in the examples, those solutions are not necessarily specific to certain disease. It doesn't matter. It kind of matters a little bit, but still at the end of the day, it doesn't. Regardless if you're polymyositis or dermatomyositis or inclusion body myositis, those functional approaches are a little different, and which is why actually there's a whole field exists as a physiatry to address those things. And again, the take-home message is maybe if you identify those problems in your function or in issues involving social integration, maybe you can think about finding a physiatrist. You can just Google around. There's some information resources in American Association of PM on our website, and probably just go start from there. And the therapeutic exercise is actually part of this kind of whole physiatric approach, which is why I spent today's actually talk more into kind of straight, talking about the basic concepts of rehabilitation and exercise. So, do you have any other questions? Yes.
I don't know what you call it, a standing walker, but it looked like a walker, but you could put your arms up high rather than having.
Repeat the question, please.
Upright walker. Oh.
So, yeah. Her question is if there's a standing walker. So I think, yeah.
Keep
Yeah.
your upright and walk instead of bending over and lower walk.
Are there any dangers to that or disadvantages?
So it's a walker, not a wheelchair.
It's a walker.
Okay.
Yeah, my brother-in-law uses one because he's relatively tall, and so walkers would work. It's a walker, it's just higher. Stands about, he's 6'3", so it just stands taller.
So you don't have to use your hands, is the one that I saw. That you can really use your forearms rather than use your hands.
So personally, I'm not familiar with that standing upright walker. The only thing that I can do.
I just wondered if it would, if you were more falling or not.
Well, I mean, I have to see the picture, but the only concern that I may have with that kind of walker would be that if you are not really looking at what your environment when you're walking, that could be a little bit dangerous. But that's the only potential concern that I have. Yes.
So just a comment to the cane. I resisted the cane for a bit, and maybe my wife buying me the back cane helped me to embrace it a bit. But somebody who had IBM a little bit before me once told me that she carried a cane because it wasn't necessarily she felt like she needed it, but it was a sign to other people that she wasn't necessarily that stable. And walking in a crowd, it, gave her a little bit of a wider berth. And I find it makes me slow down, which is not a bad thing, right? Because I tend to walk, or I used to walk a lot faster, and then you get in trouble, and I haven't had that many falls, and I think part of it's because I picked the cane up earlier. So.
There is a really good comment, and just kind of a little bit related to that is that just the same cousin who has a spinal cord injury, and I remember when he actually got spinal cord injury, he was a gymnast, he actually fell on the chin and got a fracture in the vertebra. He was a high school student, and that was back in 1980s, and those are really different times when patients actually, in rehab, he actually stayed the entire year for just rehab, and nowadays no insurance can actually allow that kind of stuff. But he's told me that the first thing that they did during that rehab is he's like 18 years old at the time, as a gymnast, and he was on the wheelchair on the mat, and the therapist actually kind of threw him, tipped him over and threw him on the mat, and kind of train him or to ask him to ask for help. And I think that's one of the other things, just more like psychological adaptation is more important too. I know a lot of people, I still like, even last week I have a lot of patients coming in, they fall down every month, every week, but they completely refuse to use even just a cane, not even a walker. And I think that, kind of understanding, meeting certain kind of functional problem, I think is also very important too. Again, you need just one bad fall, for any bad things to happen. So I think those are the things that I want to emphasize. Yes.
Getting back to the question, what she called a standing walker, I think she might have been referring to, it's basically a standard rolling walker for people who don't have enough grip to hang on to. That just has forearm rests, but otherwise it's a rolling walker.
I see. I think, yeah, if you're talking about that one, I think, yeah. Yeah, so it's not, yeah, those are just different. I mean, again, like, this, it's kind of like forearm crutch kind of stuff, so they can grab because especially the rolling walker have to have a brake. And some people, especially IBM patients, may not be able to do that. So they can bear weight on the forearm, and it doesn't really. It's not supposed to actually change their posture itself. It's just where they put the weight on. So same as walker. Yes.
Yeah, a couple of things. My wife with IBM fell and got a fracture of her wrist and had surgery with a plate put in it. Physical therapists come in and they were fitting her with a standing walker because they had to have an elevated wrist put on there too. And then we said yes, and my wife signed the paper and then found out that, well, Medicare only buys one device.
Yes.
So you do have the rolling walker, and what you said a little bit ago about having the seat on it. That is in a storage. She can put her purse underneath the seat. Said with the standing walker, she was lifting every time up, down, up, down. Even I've seen a lot of these in a nursing home where the older ladies had tennis balls on the back of the standing walker, and they have now little skis on her standing walker. Put these little skis so they slide over the cracks, because it was catching on every crack the standing walker, and even on some of the doorways you go into places, it was catching. This wheel walker with the 7-inch wheels is more ideal for an energy saving with your IBM. You do work with the people that have the prosthetic experience, let them help you.
Thank you. And also that's actually why I emphasize that when you're considering getting a walker, brace, whatever, Medicare only pays 1 out of 5 years. So that's why you really need to consult with the specialists who have a lot of experience with this kind of stuff. Because, I mean, again, like fracture may happen later on, and you can, may change, the requirement for some other things too. But again, you never know. I mean, that's why, even if it looks very simple brace or walker, I would definitely talk to therapists or physiatrists if you can find one before you go ahead and get one. Yes.
My wife has IBM.
Yes.
Falls frequently. Typically will have, the last fall, she fractured a cuboid foot. And most often it's a head injury. It's a laceration to the head. Are there any protective devices that, other than a helmet that you recommend?
Right. Well, helmet can be used in some other types of patients, mostly for traumatic brain injury patients or a little more impulsive. And I haven't had any IBM patients who had to wear a helmet because of frequent falling. That's a good idea though. And again, like I'm hoping that, to be honest, hoping that with a simple brace and a cane probably, and combination of cane and walker, you don't even need those helmets to prevent it. Because again, it depends on the fall mechanism and how frequent you fall. Like I don't know a little more detail in your environment, but most of the cases in my clinic, I think we were able to actually prevent falling itself with the brace, so we don't have to have a helmet. Because helmet is just for when you already fall, you can protect your head, but you can still have a fracture in your legs and arms too. So it'd be probably ideal if you can just prevent the fall to begin with. But of course, I mean, helmet, if you really can't do anything about it, helmet is another thing you can consider too.
So would you
Yes.
consider tomorrow through your rheumatologist?
So how would somebody get to you in your clinic? Do you have to have a referral to your local physician, or how does that?
I mean, to Hopkins Myositis Center, there's a huge referral process how we do that, and at least here, we have some Dr. Neyman, Christopher, and other doctors. We really work together, and other therapists who are invited today, Barb and Megan and Finn, they're therapists, and we took a little while, and still I'm kind of struggling with some politics in between these divisions and departments, but we were able to kind of establish some good working kind of collaborations between neurology, rheumatology, and physiatry and therapy, but that's actually not always really easy. Although I told you to kind of look for physiatry help in your local area, I have to admit that sometimes it can be a little difficult. You go to either physiatrists or physical therapists, most of the times they never even heard about myositis, and they're really usually kind of two different reactions. One is they're too scared, they don't even want to see you, or even the other extreme, which I'm really more concerned about, that, like, oh, of course I know everything about myositis, and they do whatever they want. So those are typical two different reactions. So it's kind of hard to, those are the ones that I want to talk about in tomorrow morning's talk, but I feel like the TMA is actually a great organization trying to kind of reach out to different providers in local areas. I definitely need to have more kind of network and collaboration, national, international kind of collaboration, and kind of better awareness. But yeah, I mean, to come to Hopkins, of course, you go through myositis referral, and we can go to just website, and we actually put our therapists' names and kind of profiles in the website too. So actually get them some information. Yes. Okay.
It's a little over the 4:30, so if you guys want to leave a survey in the basket or turn one in at the table, the registration desk.
Thank you very much. Thank you.
Hooray for the group TMA. It's the Myositis Association. helping patients become peers. Now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. 8,000 members they can boast. For that real strange word that no one's heard, it's myositis. There's an annual patient conference which is just second to none, where you'll learn a lot and network, and you'll also have some fun. And their website is updated with a lot of current news, with lots of info and resources, and much more that you can use, like info TMA compiles, and like lists of clinical trials, and lists of research too. You can review, cause it's all there for you. So hooray for the group TMA. It's the Myositis Association, helping patients become peers. Now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. A quarter century they can boast. They've been the group that's got the scoop on myositis.